With that, I am delighted to introduce Dr. Alvin Moss as our speaker today. Dr. Moss, known to many as Woody, is Professor of Medicine and Director of the Center for Health Ethics and Law at the Robert C. Byrd Health Sciences Center of West Virginia University. After completing his bachelor's degree in social relations at Harvard, Dr. Moss earned his MD at the University of Pennsylvania. He completed his residency in internal medicine at North Carolina Memorial Hospital in Chapel Hill and a renal fellowship at the University of Colorado Health Sciences Center. Following his formal medical training, Dr. Moss was an early figure in clinical ethics. In the 1980s, he took part in intensive educational programs in biomedical ethics at Georgetown's Kennedy Institute of Ethics, at the University of Washington School of Medicine, and at the University of Chicago's Center for Clinical Medical Ethics. Dr. Moss's efforts to address what economist Victor Fuchs originally called medicine's technological imperative in his own field of nephrology has resulted in a powerful ethical and clinical examination of the default to dialysis for patients with kidney failure. Following work on the Institute of Medicine's project on Medicare's end-stage renal disease program, in the late 1990s, Dr. Moss led efforts by the Renal Physicians Association and American Society of Nephrology to develop an evidence-based clinical practice guideline for the initiation and withdrawal of dialysis. Following publication of the guideline in 2000, he continued to examine and critique the evidence base for dialysis in chronic illness and end-of-life care. And he subsequently chaired the working group to revise the clinical practice guideline, which was published in 2010. Nonetheless, as we will hear from Dr. Moss today, the technological imperative continues to be a source of ethical challenges in the care of patients with chronic ailments and those at the end of life. His talk today is entitled, "The Dialysis Default is Increasingly Problematic for Older Patients with Kidney Failure." Please help me welcome Dr. Alvin Moss. Thank you.
Liz, thank you for that very nice introduction. I don't know that anybody has delved into my past as much as you just did, so thank you very much. Let me see if I can get the next slide. There we go. So this is actually not the slide for this talk, but I wanted to present it to create the context and really introduce the sub-theme of moral distress that at least runs throughout a minority of the nephrology community, if not a majority. So every year for at least the past 5 years, I've been a speaker at the early program of the American Society of Nephrology on critical care nephrology. And this is the title of the talk that I gave, "The Ethics of Acute Kidney Injury in the Intensive Care Unit. When can you say no?" I actually changed it to "When should you say no?" And I give this talk, and at the end of the talk, the usual response is that a number of nephrologists really say, "I've been thinking this all along, I agree with you." But what's been most interesting to me is that nephrology fellows, 3, 5, sometimes 7 or 8 will come up to me at the end of this talk and say, "I'm so glad to have heard your talk. When I'm called to the intensive care unit to evaluate a patient for dialysis, the intensivist has already told the family, we're going to do dialysis, so I feel more like a dialysis technician than really using my training and expertise to make a recommendation either for or against dialysis." So this sub-theme of moral distress I want to introduce because it's going to come back pretty quickly in this talk. So I titled this talk, "The Dialysis Default is Increasingly Problematic for Older Patients with Kidney Failure, and I have no relevant financial relationships to disclose." My objectives are to present the outcomes of dialysis for older patients with comorbidities. And the reason why I said in my title, it's increasingly problematic, because as you'll see as we review the evidence is pretty consistent about which patients are likely to benefit and especially which patients are not likely to benefit from dialysis. Discuss default options in medicine and their consequences for patients with kidney failure. Explain the status of the American Society of Nephrology choosing wisely recommendation to conduct a shared decision-making process prior to the initiation of dialysis. I might add that in 2010, this clinical practice guideline that Liz alluded to was published. And then in 2012, we were gratified to see that the American Society of Nephrology picked up the recommendation for a shared decision-making conversation, one of their 5 questions that nephrologists should discuss with patients and families. And then perhaps in really consistent with Liz's introduction, describe the yet to be implemented patient-centered range of options for treatment of kidney failure in older adults. So there's still work to be done, even though the clinical practice guideline calling for the work was published 21 years ago now. So Mr. G and moral distress in the nephrology fellow. A couple of weeks ago, I did a workshop for an academic medical center nephrology program and asked if they could ask their nephrology fellows to write down and present one of their most troubling cases in the last year. And one of the nephrology fellows presented Mr. G to me. Mr. G is an 82-year-old man with progressive Lewy body dementia. His past medical history included stage 4 chronic kidney disease. He was followed by a nephrologist. For those clinicians in the audience, his eGFR was 20 milliliters per minute. Over the course of the last couple of months, he had had deteriorating mental status and progressive functional decline. A couple of months ago, he was admitted to the emergency department. He was hypothermic, hypotensive, and on workup for infection, he was found to have both an aspiration pneumonia and septic shock. Further evaluation revealed that he had a deep sacral pressure sore that was infected with underlying osteomyelitis. Because he was thought to have uremic encephalopathy, he was started on dialysis. His functional status was that of being bedbound. He was unable to transfer from bed to chair. And I'm sure that probably very few in the audience know that ability to transfer the lack of an independent ability to transfer was identified as one of the most important useful predictors of patients unlikely to do well on dialysis in the French Renal Epidemiology and Information Network. At discharge, his family wanted to continue dialysis. The nephrology fellow is presenting this case to me. She was distressed over the initiation of dialysis, now the planned continuation of dialysis, and she was really concerned about overtreatment and causing more harm than good. And moral distress among physicians is really very common regarding a life-sustaining treatment and what the physicians feel is inappropriate overuse of the life-sustaining treatment. So what do the data show? This is a study. On the left-hand side are patients with low comorbidity scores. And on the right-hand side are patients with high comorbidity scores. And you'll see that there is a survival advantage to patients starting dialysis who have low comorbidity scores and not a survival advantage over what we would call conservative management or active medical management without dialysis for patients who have higher comorbidity scores. And John, I saw that a hand was raised. I'm going to leave it to you to decide when to interrupt. Feel free to interrupt and ask questions as appropriate. And this is another study, again, looking at patients with high comorbidity scores, patients over the age of 75. And again, note there was not a survival advantage to those who were dialyzed as opposed to those who received active medical management without dialysis. And then in a study, perhaps many of you know this, in 2009, there was a study of over 3,700 nursing home residents who, while already nursing home residents, were started on dialysis. The majority of them died in the first year, 29% lost function, only 13% maintained pre-dialysis function. But what families are often told, oh, we'll start dialysis and your loved one will improve and gain function, did not happen with a single patient. And then this is a European study, again, comparing patients who started dialysis, older patients who started dialysis versus those who did not. And there was no survival advantage for patients over the age of 80 with dialysis as opposed to conservative management. And notice that here, severe comorbidity was very predictive of outcomes. And in fact, in this study, they noted that patients over the age of 70 with significant comorbidities, there was not a survival advantage to starting dialysis. So I'm hoping I'm building the evidence base for you. And note that even though we have this American Society of Nephrology choosing wisely recommendation, even though we have the clinical practice guideline recommendation that drew attention to these factors that predicted a poor prognosis starting dialysis, this was a study looking at dialysis patients stratified by age. Notice in the rectangle over here, 85 and older, and the majority of them had either started dialysis or were being prepared to start dialysis, even though they had high comorbidity scores and could be predicted to do very poorly and maybe not have any survival benefit at all from starting dialysis versus active medical management without dialysis. So in the review of the medical evidence that led up to the two clinical practice guidelines, these in this list here were statistically significant independent predictors of a poor prognosis for for patients with kidney disease. Age was one, comorbidities was another. Comorbidities seemed to be the strongest predictor of a poor prognosis. Functional status was another. I alluded to the fact that Mr. G was bedbound, had very poor functional status. Nutritional status was another one. Frailty is another one, and cognitive impairment is another one, especially including dementia. This is yet another study. I just really want to hope that I've convinced you. This was a novel study because Melissa Wachterman and her team followed patients from day one of starting dialysis. These were Medicare beneficiaries, age 65 and older, starting dialysis. And unlike the United States renal data system that waits until day 91 to enter them into the registry, she looked at survival outcomes starting from the first day. And what she noted is that if you start during the first day, a quarter or almost a quarter of these patients had died within 30 days, almost half were dead within 6 months, and over half had died within a year. And this is almost double the 1-year mortality rate reported for older patients in the United States Renal Data System registry. So the point of this is actually older patients have a worse survival prognosis than we had previously thought using the USRDS data. And then when she looked, multivariate logistic regression analysis, look at the factors significantly associated with a higher 1-year mortality, notice that dependence in one or more activities of daily living was there, the functional impairment, age 85 or older, inpatient dialysis initiation. Mr. G, as you noted, had inpatient dialysis initiation, and he also had 4 or more comorbidities. So in her discussion, Dr. Wachterman and colleagues noted the limited survival among older patients who initiated dialysis may help to frame prognostic expectations and support more informative discussions about dialysis initiation in older adults. And I helped develop this prognostic estimator. It's a calculator, online calculator. Here's the website address for this. And if you plug in Mr. G's serum albumin, the fact that I would not be surprised if he died in the next 6 months, that he was 82 years old, that he had dementia, but he did not have peripheral arterial disease, his predicted 6-month survival is 20%, and his predicted 12-month survival is 2%. So really the prognostic calculator that really was derived in one patient population and validated in another one really seems like it's probably pretty accurate and pretty consistent with the other studies that I've presented to you. Now, enter, however, the default, what's you're going to see in the next 2 slides called the powerful dialysis default option. And in a sounding board, Scott Halpern and colleagues at Penn noted that default options strongly influence behaviors, that some people may be harmed by default options. And for those likely to be harmed by a particular default, he and his colleagues recommend that really there be a forced need to conscientious and deliberately make a decision, that really not allow the default to operate, but that really there be an explicit, intentional decision to sit down and discuss this through and not just to go along with the default. Now, this is an article that really builds on this whole idea of the dialysis default. And actually, there's a medical anthropologist, Sharon Kaufman at the University of California at San Francisco, has written a lot about that. And I'll refer to her a few more slides down the line. But as they analyzed the charts of 851 adults in the VA Veterans Health Administration over an 11-year period who had chosen not to start dialysis, qualitative analysis, they identified three themes. When patients wished to forego dialysis, it was unusual for clinicians to readily accept their decision. Patients who did not wish to start dialysis had to resist immense pressure from clinicians. It's almost as if they were badgered or bullied or harassed. And I forget which of those, but I know the authors did use at least one, if not several of those words to describe how the patients felt with regard to this process. Now, on the other hand, clinicians viewed some patients as not appropriate for dialysis, usually on the basis of specific characteristics and or prognosis. And so they were viewed as not candidates, really more because these objective characteristics and prognosis rather than really what the patient's values were. And it was clear, when it was clear that patients would not be starting dialysis, nephrologists often signed off and had few recommendations other than referral to hospice care. And I don't present this to really present nephrologists in a bad light, because it was published by nephrologists at the University of Washington in Seattle, really expert researchers with geriatric nephrology. And what they concluded was that these findings describe an all or nothing approach for patients with advanced chronic kidney disease, in which initiation of dialysis served as a powerful default option with few perceived alternatives. And by the way, let me sort of parenthetically add, I am going to talk about alternatives at the end of this talk, just to give you that a little heads up. So they concluded stronger efforts are needed to develop a more patient-centered approach to caring for patients with advanced chronic kidney disease that is capable of proactively supporting those who do not wish to start dialysis. And if you recall, the Institute of Medicine defined patient-centered as really an approach that's respectful of and responsive to patients' values, preferences, and goals. So really a call for a more patient-centered approach to dialysis decision-making. So the shared decision-making and the appropriate initiation of and withdrawal from dialysis guideline, the second edition came out in 2010. Liz alluded to it in her introduction. It's evidence-based. There are 10 recommendations. There are practical strategies based on each recommendation. I'm trying to recall whether there were 300. I know there were at least 300 articles that were reviewed to form the recommendations in this clinical practice guideline. And for those of you who are curious, 35 nephrologists, bioethicists, health policy experts all participated in the guideline development. So the American Society of Nephrology, choosing wisely recommendation that the American Society of Nephrology published in 2012, said limited observational data suggests that survival may not differ substantially for older adults with a high burden of comorbidity who initiate chronic dialysis versus those managed conservatively. And what I've done is presented to you studies that have been published since 2012, bearing out the limited observational data that was available to the American Society of Nephrology in 2012. Sadly, despite recommendations to the contrary, shared decision-making remains poorly integrated into the care of patients with advanced chronic kidney disease. I already showed you one study by Wong et al. That showed the majority of older patients who could be predicted to have the worst outcomes, still the majority of them were still being started on dialysis. Just to review for 1 second, the shared decision-making recommendation, what should occur. I like this article from the New England Journal of Medicine from 2012. Michael Barry and I think her name was, I forget the name of his co-author. They said that really shared decision-making was the pinnacle or the very height of patient-centered care. And they described a process, not a one-time event, a process of communication between patient and physician based on the patient's overall condition, They reach agreement on a specific course of treatment after the patient describes values, preferences, and goals. The physician presents the diagnosis, prognosis, treatment alternatives with their attendant benefits and risks. As a result of this process, each participant better understands the relevant factors, and really it's hoped that they share responsibility in the decision. And if we think about Mr. G for just a minute, this Mr. G was followed by a nephrologist. He had multiple factors that would have predicted a poor prognosis with starting dialysis. And yet when the time came, he was started on dialysis. And I'm sure that contributed to the moral distress of the nephrology fellow who knew the literature and was aware that it was really very unlikely that Mr. G would do well starting dialysis. And in the interest of sticking to the 45-minute time that I was allotted to give this presentation, I cut out a couple of other slides. But Susan Wong and co-authors also published a study in the Clinical Journal of the American Society of Nephrology in 2016, in which she looked at dialysis starts in the hospital based on age. And those over the age of 80 did very poorly, especially if they had had other intensive procedures like mechanical ventilation or CPR or a feeding tube insertion. And they often spent much of the remaining months of life, and I think the average survival was 5 to 7 months after starting dialysis, and the 85-year-old and older spent up to 40%. So they basically spent 2 of the 5 months of remaining life in the hospital because of subsequent complications. So it's really the recommendation that a shared decision-making process with the elements on the slide occur prior to the initiation of dialysis. Now, I was really glad to see this article in last summer's New England Journal of Medicine, Ensuring Choice for People with Kidney Failure, Dialysis, Supportive Care, and Hope. And the authors describe options, the alternatives that I alluded to in a previous slide, starting dialysis incrementally, not going immediately to 3 times a week, 4 hours at a time. If the patient has some residual renal function, starting older patients where there's really is insistence on the part of the family and the nephrologists are willing to it, well, there is a possibility the patient might benefit. Starting it as a time-limited trial of dialysis instead of a commitment to maintenance dialysis without any limits on how long it would go on. Active medical management without dialysis is really way underutilized in this country. It's utilized much more often in Europe, in Australia, New Zealand, Canada, and then palliative dialysis. Even this idea that we recommend, we recognize from the outset, this patient is not likely to do well on dialysis, not likely to live even a year, and that although survival is one value of importance to family, other things like quality of life or of importance to the patient, other things like quality of life are even more important. And so patients on palliative dialysis may come for only 2 times a week or 1 time a week. They may have shortened treatments because really it's patient-centered care. It's individualized to the values of the patient. Sometimes the patient and the family, maybe they want to live for 2 months until their granddaughter gets married, or they're expecting a birth of a grandchild, or there's some life event. And really that's what they're living for. And so that's the reason why they might undertake palliative dialysis. Now, enter the technological imperative. Liz, in her introduction, referred to Victor Fuchs, who coined the term the technological imperative, and applying it to dialysis. If you can do dialysis, you must do dialysis. And from an ethical perspective, what's wrong with the technological imperative is it may not benefit the patient, may cause more harms than good. So, and I don't know how the group at UT Southwestern, the ethics group, views this particular book, which is now in its 8th edition by Al Johnson, Mark Sigler, and Bill Winslade. And I think Bill spent a good part of his career as a clinical bioethicist in Texas. But at any rate, they recommend a 4-step approach to ethical case analysis and really say, look at the medical indications first. Really, you shouldn't even ask whether the patient prefers it or not if you think the harms are going to outweigh the benefits. So this is really a helpful way to think about things as you're doing your ethical analysis and as you're approaching cases about what should be done. Now, another issue to be dealt with in addition to the technological imperative is what's been called the biomedicalization of aging. And biomedicalization of aging has led to the routinization of clinical interventions for older patients. Standard practices replacing choice. Societal expectations about standard medical care have resulted in how kidney failure in older patients is treated, and nephrologists feel obligated to dialyze all elderly patients. And when I meet with these nephrologists at this annual meeting in the American Society of Nephrology and talk to them, the vast majority really feel everybody is expecting that they're going to start the patient on dialysis, regardless of the patient's overall condition, regardless of the patient's comorbidities, functional status, nutritional status, regardless of how frail they are or how bad their dementia is. And so the technological imperative has become what's been described as the moral imperative. You know, if you can do it, you must do it. Goals of medicine to cure and prolong life are now in conflict with those to minimize suffering and maximize quality of life. I alluded to Sharon Kaufman already, the medical anthropologist at the University of California at San Francisco, who, by the way, has written some great books, including one called Ordinary Medicine. If you're looking for a good read, that's one I encourage you to read. So they've reported, because they've done interviews with patients with kidney disease, and they report that many patients are not even aware that they have a choice. It's not if you want to start dialysis, it's when you need dialysis. In other words, there is no choice. It's in your future. This is something that's going to happen. So nephrologists have been influenced by the technological imperative, which has become a moral imperative to treat all kidney failure, meeting criteria for dialysis. So, you know, the criteria that we probably still teach, probably in Texas, you still teach it to AEIOU, the indications for dialysis, acidemia, you know, intoxication, fluid overload, uremic encephalopathy, electrolyte imbalance. Presumably, if they meet those criteria without really giving any thought to the patient's overall prognosis, often those patients are started on dialysis. So enter in the shared decision-making, the clinical practice guidelines, shared decision-making recommendations. And the first recommendation is to develop a physician-patient relationship for shared decision-making. And it says that shared decision-making is the recognized preferred model for medical decision-making because it addresses the ethical need to fully inform patients as well as to discuss the burdens and benefits of treatment and to ensure that patients' values play a prominent role in the decisions. And notice as it relates to Mr. G and to all patients, it recommends that patients be given an estimate of prognosis specific to their overall condition. And it even recommends which patients it would be appropriate to forego dialysis or to withhold or withdraw dialysis. And this is, this is not, this is not going to be shocking to people. If the patient with decision-making capacity says, no, I don't want dialysis, then it would be appropriate. Patients have the right of informed refusal not to start that patient on dialysis. Patients who no longer possess decision-making capacity have previously indicated, either verbally or in a written advance directive, they do not wish to have dialysis. Obviously, we should respect those wishes. Patients who no longer possess decision-making capacity have not given prior expressed wishes, but who's properly appointed legally authorized representative, whether it's called a healthcare agent, a medical power of attorney, a durable power of attorney for healthcare agent, or a healthcare surrogate, but they are functioning in their role to make decisions for the patient, and they refuse dialysis or request that it be discontinued. And then one that really has come up as a result of my research and the research of others, patients with irreversible, profound neurologic impairment, such that they lack signs of thought, sensation, purposeful behavior, and awareness of self and environment. And way back when I first got into this field, I surveyed nephrologists and I asked them, would you start a permanently unconscious patient on dialysis? And at the time, a good third of nephrologists said they would, even though we had articles, things published even in the 1970s saying that if there's no potential, no relationship potential, that really how can we say there would be a benefit to providing dialysis? But still, many nephrologists still reported that they would start dialysis if the family requested it, really irregardless of whether they thought it was the right thing to do or not. So you can see how moral distress, there's really a setup for moral distress in the nephrology community. And I forget if I mentioned in the introduction that in a recent paper that I reviewed, a good quarter of nephrology fellows reported moral distress over of their dialysis when it was offered to patients. And even a fair number had considered leaving their nephrology fellowship program because they were distressed by what they saw going on. So some of you in the audience may be aware that nephrology in its match and its recruitment doesn't do very well. And certainly if we could decrease the moral distress among our nephrology fellows, that would be a good thing to do. Maybe the word of mouth would improve and more internal medicine residents would want to go into nephrology. So now this is really now where we're getting to Mr. G, and I think this might apply to Mr. G. Consider foregoing dialysis for acute kidney injury, chronic kidney disease, or end-stage renal disease for patients who have a very poor prognosis or for whom dialysis cannot be provided safely. Clearly, I've shown you already, Mr. G has a very poor prognosis, predicted 20% 6-month survival, 2% 1-year survival. And even with his dementia, there's a real concern about, will he be able to cooperate with the dialysis process? Will he try and pull out his needles? I can't tell you how many dialysis patients we've had issues with as their dementia got worse. They didn't understand the process at all. They would try and pull out their needles because the needle sticking through their skin was irritating to them, or the tape was pulling on their skin. And I would actually, and don't think ill of me, sometimes I would ask a dialysis patient on dialysis as I'm making dialysis rounds, why is that tubing red? And the poor demented patients would have no idea that blood was circulating outside their body through the tubing, through the dialysis machine, and back to them. So they really just had no understanding of what was going on. And when they would get agitated, we would then ask the family to provide a sitter so that we could safely provide dialysis. And then even with a sitter, if they still were agitated, then it really became an issue of, should we really be doing this? Is it safe for the patient? If the patient really pulls his or her needles out, especially in the early days before our blood pumps didn't shut off quite as quickly after a needle dislodgement, there was the risk of blood being aerosolized throughout the dialysis center and other people or staff, potentially coming in contact with blood. So really, this whole issue of can we provide it safely is still really an issue. And can the patient tolerate dialysis? Also, hypotension on dialysis. I didn't include it in this slide, but Mr. G was hypotensive with almost every treatment, which was making dialysis more and more of a challenge. We've said consider a time-limited trial of dialysis for patients requiring dialysis who have an uncertain prognosis or for whom a consensus cannot be reached about starting dialysis. And I for 32 years, I led our ethics consultation service at our university hospital. And we frequently dealt with issues where a consensus could not be reached about use of dialysis or other life-sustaining treatments. And sometimes a time-limited trial was a really good thing to do. It really gave us more information about how likely what patient was to benefit from dialysis, but also gave the family an opportunity to see how well the patient tolerated dialysis. And I can tell you that a number of times when we set it up as a time-limited trial, sometimes the families came to us and said, let's stop. And I said, well, we had agreed to go one more week. And they said, no, let's stop. It's just not working. Dad's not doing well. He's totally washed out after the treatment. He's miserable. We can see he's suffering. We want to stop. So really the time-limited trial can really be very helpful. So my recommendations for evaluating the older patient with kidney failure are all of you, whether you're ethics consultants, nephrologists, general internists, I'm not sure who is in the audience, nephrology nurses, nurse practitioners, physician assistants. what's the patient's age? What are the comorbidities? How severe are they? Is the patient frail? I didn't mention it, but frailty doubles the risk of early mortality. What's the patient's functional status? Are they in a nursing home? What's the patient's nutritional status? These are all risk factors for a poor outcome with dialysis. What's the overall prognosis? Do they have multiple of these factors? Is dialysis medically indicated? Going back to that process of ethical decision-making, first, decide whether or not you think the benefits are likely to outweigh the harms. And then ask yourself, will the patient be able to tolerate the process? Is he going to become hypotensive with every treatment? And will you have to cut dialysis short? Will the patient be able to cooperate with the dialysis process? Will the patient be able to understand what's going on and sit still and not dislodge needles and not cry out and be disruptive to the entire dialysis center? Is the patient decisionally capable? Can they participate in the decisions? What are their values, preferences, and goals? And if they're not decisionally capable, do we have advanced directives? Do we know what they would want? Who is the legal decision maker? Did the patient specify treatments that were wanted or not wanted? And were there circumstances in which the patient said, even though they'd be willing to start dialysis, did they say, if I have a massive stroke and I am no longer awake and alert, I would not want to continue dialysis? And surveys that have been done of dialysis patients, advanced dementia, severe coma have been things that have been mentioned by roughly 20% of patients as reasons why they would want to stop dialysis. As Liz said, I've been thinking about this topic for a long time. So just last month in the Journal of the American Geriatric Society, with a colleague, Osvaldo Navia, who's a geriatrician, we published this commentary: should we recommend dialysis for older patients with kidney failure and dementia? And to have some fun and really see what the audience is thinking, we're going to take a poll. Oops. Hold on one second. Don't answer that one. So the question is, should we recommend dialysis for older patients with kidney failure and dementia? So I'm going to launch this poll. Okay. And if you want to go ahead and vote, please go ahead and vote. And let me see how many of you are going to recommend dialysis for the older patient with kidney failure and dementia. All right, so we're doing well. This is great. We already have over 70 responses, and it's going up quickly. I'll wait till it looks like okay, so we have 111 responses, still going up. I'll wait just a little longer. All right, well, I think I'll probably end the polling at this point. We have 120 responses. Let me share the results. You can see that 87% said no and 13% said yes. And when I shared the same question with academic nephrologists at a university nephrology fellowship program, the results were almost identical. 9% said yes, we would recommend dialysis for older patients with kidney failure and dementia, and 91% said no. Now, I admit that you certainly want to know, is this early dementia? Is this moderate dementia? Is this advanced dementia? What more do we know about the patient? How likely are they to be able to cooperate with the dialysis process? But all things being considered equal, the vast majority said no, we shouldn't recommend it. I didn't say, by the way, and we'll get to this, I didn't say, should we not offer it? The question really was, should we recommend it? Now, hold on. Okay, so in the article, we gave 5 reasons for why people might want to question offering dialysis for patients with dementia. And these are evidence-based. Older patients with kidney failure and dementia may not live any longer with dialysis than without it, especially if they have other comorbidities, and older patients with dementia typically do have other comorbidities. They have a 2-fold higher mortality risk compared to age-matched patients on dialysis without dementia. They're less likely to do well on dialysis. And if you look at the dialysis literature, which patients are most likely to withdraw from dialysis or stop dialysis, patients with dementia are right up there at the top. Geriatricians have really described the dialysis center as a dementia-unfriendly environment. It's not very forgiving. I mean, you really have to sit still. You have to hold your arm just so with the needles in your fistula or your graft, or, hold still as they, have to connect you up to your tunneled cuff catheter for dialysis. You have to be able to cooperate with the dialysis process. You can't just get up out of your seat and bolt somewhere with dialysis lines connected to you. And then the other thing that's interesting is dialysis patients experience a significant decline in their cognitive function shortly after starting dialysis. Their executive function is known to deteriorate, and it deteriorates to a much greater degree than patients, who do not have dementia on dialysis. All right, so in the article, the key points that I've already alluded to, and as I've already told you, that the default is to start them on dialysis, older patients with kidney failure and dementia. And why the paper mattered is because we argued instead of the default, we called for explicit shared decision-making with treatment options other than the usual in-center and home dialysis options. And in point of fact, this was the figure in the paper. And notice for older patients with dementia and comorbidities, we recommended consideration of active medical management without dialysis, palliative dialysis, a time-limited trial of dialysis, instead of the usual kidney replacement therapies of dialysis or transplantation, and for dialysis, home hemodialysis or in-center. Of course, it could be home peritoneal dialysis as well, but if they have dementia, it may be more problematic. They may not understand the catheter going through their abdomen. They may pull at it, and I've had many families of loved ones with dementia and kidney failure say, no, we could never do peritoneal dialysis. They would pull at it. We really need to put that tunneled cuff catheter in an up, out of the way place so that he or she can't get to it. So now let's come back to Mr. G, and I'm going to poll you one more time. Mr. G, if you recall, was 82 years old with progressive Lewy body dementia, had a stage 4 pressure sore, was malnourished, had been septic. He was also aspirating. I left out the part about the speech pathologist wondering whether or not he should have a percutaneous endoscopic gastrostomy feeding tube. He received urgent dialysis for uremic encephalopathy. The family wanted to continue dialysis. And my question for you is, what would you recommend for Mr. G? So obviously we would want to, in advance, have a shared decision-making process. And let me bring back the poll. And let me get to the second question. So would you want to, and let me relaunch the polling. Would you want to not offer dialysis and instead recommend palliative care with active medical management without dialysis and hospice? Would you want to recommend against maintenance dialysis because there's a low likelihood of benefit and a high likelihood of harm from it, and offers alternatives, active medical management without dialysis, palliative dialysis, and a time-limited trial of dialysis? Would you want to recommend a time-limited trial of dialysis to determine the relative benefits and harms? So let's see how the audience feels about this. All right, the numbers are still going up quickly, so we'll keep watching. We've exceeded over 100 voting and still going up. All right, so this is an interesting spread. It looks like, well, we've now have we've exceeded over 120 voting. So even more responding this time than on the previous one. I think this is a really good question to assess what people are thinking. Okay, should we end the polling? Let's share the results. All right, so 33%, I'm very impressed. 33% they would not offer dialysis and instead recommend palliative care with active medical management without dialysis and hospice. And you might wonder, how could you do that? And I guess I better finish up quickly here, but you might say something like, your loved one. We have guidelines that indicate which patients are really good candidates for dialysis, which ones are likely to benefit from dialysis. And I'm sad to say that unfortunately, your loved one is not one who is likely to benefit from dialysis. It's more likely to cause more harm than good. And so therefore it's not something we would offer, but instead we would recommend, and then you could recommend active medical management without dialysis in hospice. You could, if really the family just is giving you a really hard time, or if you're just frankly one of those clinicians who just really doesn't feel right about not offering a treatment, you could recommend against maintenance dialysis because of the low likelihood of benefit and high likelihood of harm, and offer active medical management without dialysis, palliative dialysis, or a time-limited trial of dialysis, and saying after a couple of weeks or after a month, let's reevaluate where we are. Let's do our time-limited trial right. Let's identify in advance the goals we're trying to achieve. And then at the end of that time, we'll decide whether or not we've achieved those goals or not. Or some of you, 10% of you, wanted to recommend a time-limited trial of dialysis to determine the relative benefits and harms. And let me just tell you, as I've talked to nephrologists in this critical care nephrology early program at the American Society of Nephrology, the feedback that I've been given over the years is one of the most useful things they've learned from my talking to them, is that when they really don't think they should do it, but they really are just unable to convince the family otherwise, is that they might set it up as a time-limited trial with the understanding that they're going to stop if it's not benefiting the patient. All right, so let's move on to the next slide. So the bottom line, analyze the patient's overall condition, taking into account factors known to influence prognosis prior to offering dialysis to older patients with kidney disease. And so the sad thing with regard to Mr. G is he was being followed by a nephrologist. He already could be predicted to do very poorly with dialysis, but yet it does not appear that that conversation was held. Review advanced directives if the patient lacks decision-making capacity. Dialysis should not automatically be offered to older patients with kidney failure, especially if they have underlying significant comorbidities. Start dialysis as a time-limited trial for those for whom the benefit is uncertain and the patient or legally authorized representative wants to proceed. Nephrologists can say no to dialysis when the burdens are predicted to substantially outweigh the benefits. That's the Hippocratic maxim: be a benefit and do no harm. And if really you're struggling to reach agreement with the family, consider an ethics, palliative care, supportive care consult. I'm not sure what is available to you where you practice for cases in which dialysis can be predicted to be of limited or no benefit, but the patient and family are requesting it. And then my last slide, if you've liked this, I just want to call your attention to the fact that Oxford University Press published a book last summer. I was one of the editors, Palliative Care Nephrology, which goes through a lot of the content that we've had in this talk, and you can read more about all different aspects of primary palliative care skills for taking care of patients with kidney disease. We also have a active medical management without dialysis pathway. So some nephrologists might say, yes, I agree, active medical management without dialysis is appropriate for 10% of my patients that I'm following with chronic kidney disease. Here's a place where you could go to get some tools to be able to implement that in your practice. And then this is a poster, actually. We have been able to move the needle. We did a Pathways Project multimodal intervention to improve supportive care in dialysis centers. And as a result of the intervention, we improved the identification of seriously ill patients and increased goals of care conversations with them. So John, let me stop here. I'm sorry, I probably talked a little too much, but let's see if there are any comments or questions in the chat.
So Dr. Moss, thank you very much for a really engaging and relevant talk. You've had great response in the question and comment column. And in fact, there's no way we're going to be able to get to all of them. And so let me just lead off by asking people who placed questions or comments in the chat box and did not leave your email address, please do so. And Dr. Moss has indicated a willingness to respond to you later to your question. That may be a decision
I'm going to tell you what,
Woody.
Yes. I'm typing to save people. I just type my email address in. Okay,
Oh,
so they
you
can feel free.
contact him directly.
Yeah.
Terrific.
Yeah.
So if I may, early on from Ryan Getz, we had a question about looking at the studies with, showing no difference in prognosis with and without dialysis. But is there any indication if there's quality of life differences in those two groups?
So that's a really good question. And as it turns out, Steve Weisbord, who's a nephrologist at the University of Pittsburgh, specifically looked at symptom burden at patients who start dialysis versus those who do active medical management without dialysis. And there was no reported difference in quality of life. The one thing we know is the patients who did not start dialysis reported that they had greater independence, they had more freedom to travel, and that really they valued that very highly.
Well, that's useful. So a second question, they're sort of interrelated, an interest in the sources of pressure from towards clinicians to initiate dialysis, including laws or threats of lawsuit and so forth. Any information about that and how to respond?
Yeah, so it's interesting. Years ago, we surveyed US nephrologists, Canadian nephrologists, and British nephrologists and gave them some of these very sick cases like the one I described today. We even included a patient in a persistent vegetative state. And what we found out is that the American nephrologists were significantly more likely to start these patients. And we asked them why. It was concerns, legal concerns. Okay, there clearly was a financial pressure. Often it wasn't the nephrologist, but it was the institution or their dialysis organization. They were part of someone, a group that wanted patients on dialysis, and therefore there was pressure to start patients on dialysis. So the legal pressures, the financial pressures, then the societal pressures, I alluded to them. The biomedicalization of aging, the routinization of these procedures in older and older people, the family pressures, because they have not really been adequately counseled earlier in the patient's course about how they're doing and how they're likely to do if they were to be started on dialysis. So I would identify those three.
Very good. We also had a question about Medicare's funding around these decisions, and how does this play into these sorts of concerns?
Yeah, so unfortunately, Medicare doesn't really fund well a shared decision-making conversation. You can bill for prolonged time, or you could bill for an advanced care planning discussion, your Medicare code 99497, and if it's 31 minutes or 46 minutes, I guess, 994982. But really, it's not reimbursed nearly as well as starting the patient on dialysis, and it takes a fair amount of time. And really, not all nephrologists have the communication skills because these can be complicated conversations. John, if you don't mind, Harold Malofsky just put a question that I'd love to address. He said, would you consider adding the Charleston Comorbidity Score and the Johns Hopkins Frailty Index as measurable scores in the mortality predictor calculator? So Harold, just so you know, we initially gathered the Charleston Comorbidity Score and had all that data, but as our statistician analyzed it, she not only took the overall score, but she also took each comorbidity individually. And that's the reason why we only have peripheral arterial disease and dementia in the calculator, because the other comorbidities and the overall score fell out. If I were doing it again now, I would definitely include a frailty index in it. Now, whether or not the frailty index would remain in multivariate logistic regression analysis, I don't know, but you're absolutely right that we should be considering frailty because it doubles the risk of early mortality in these patients. Sorry, John, that's just a question I wanted to answer.
No, that's absolutely fine. And if I could return though back to the Medicare question, I think the ramification also was, given the various options that you, for example, offered in the polls, are there differential payment arrangements offered by Medicare, and is Medicare funding this of options a driver for decision making?
Oh, absolutely. Yes, it's a very sad story. So when I talk to nephrologists, many of them agree we'd like to offer palliative dialysis, but if we do palliative dialysis, our quality metrics that CMS measures are going to go down and we're going to be penalized and we may be reimbursed less. So there's a financial disincentive to provide patient-centered dialysis patient care. And then even, we think the best quality care at the end of life for dialysis patients would be concurrent hospice and dialysis. But unfortunately, the way CMS guidelines have gone, it's not available for the vast majority of dialysis patients who are dying. They have to be dying of a clearly diagnosis like lung cancer. And even then, some hospices just won't take a dialysis patient unless they agree to stop dialysis. So absolutely, the financial incentives, Medicare is not helping us provide quality care to our dialysis patients.
Very good. Thank you. We've had several questions about language and cultural barriers to having these discussions. You want to speak to that?
Oh, absolutely. Yes, that's another layer where we need to develop skills. Okay, we really know that we need to have language interpreters, cultural interpreters. We know we shouldn't allow the family to serve in that role because the family has emotions and commitments. And so really, it's extremely important. And, in this Pathways project that I alluded to, we were working with 6 dialysis centers in New York City, and they had many, many patients from many different nationalities, many different languages. And really, have to give them credit. They were using language interpreters and they were trying to have these conversations. And honestly, this is hard enough to do, to convey the nuances and the subtleties in English to people who are also primary English speakers, and to have to go through it with a cultural interpreter, language interpreter, it just makes it that much more difficult. We do the best that we can, but I agree with your audience who's commenting that yes, this adds another layer of complexity.
We probably should have this be the last question.
Okay.
This is a comment from Bob Fine about the situation where you were working with a family and surrogates, and that they're trapped by grief or perhaps motivated by other gains, secondary, financial, etc., and may be questionable or as being interested primarily in the patient's interest. Do you have any ideas, responses about working with those families?
Yeah, I just had a family like that last year. It was probably my most challenging case of last year. And this was a patient really anoxic encephalopathy for 6 weeks. The neurologist said, this one is just not going to wake up. We don't see that that's going to happen. And we basically said to the family, I'm sorry, we have guidelines. Your loved one is not one that falls within those guidelines. We're not going to do dialysis. They said, well, we want you to transfer to, so I'm at West Virginia University Hospital. They said the Cleveland Clinic, UPMC, University of Pittsburgh Medical Center, Johns Hopkins. We called all 3. They wouldn't accept the patient either. And we said, we're not going to dialyze your loved one any further. We'd already started and we just announced we're going to stop. We're not going to do it further. They weren't happy, but they understood that no one, there were guidelines and no nephrologists, including the ones at the institutions they chose, were willing to do it. So Bob, that's what I would say is sometimes, it's regrettable. It's unfortunate, but not unfair, as a bioethicist from Texas might say, that's the case.
So Woody, thank you so much for a very articulate, thoughtful, and rigorously defended set of policies and analyses. And thank you for our audience for your great participation. We'll have to sign off now with regret.
Yes. All right. Great to talk to all of you. Thank you.